This videotape is intended for families and mental health workers involved in the treatment and rehabilitation process of schizophrenia. Our presenter is Dr. William R. McFarlane, Chief of Psychiatry at the Maine Medical Center and a leading authority on schizophrenia.
Hello, my name is Bill McFarlane. I'm a psychiatrist working at Maine Medical Center in Portland, Maine. I've been working with people with schizophrenia for about 30 years, and as well with their families. This videotape and the material in it is an attempt to provide you with as much information as is presently available about this illness, and hopefully some guidance about ways you can help contribute to recovery from what is in fact a very serious mental illness. On the other side, we found that working more closely together can have truly dramatic effects on clinical outcomes and what we call functional outcomes, that is, the ability to live independently and carry on life as one chooses. It tends to tremendously alleviate a lot of the suffering that families experience, and surprisingly, much of the suffering that the individuals with the illness also experience. We hope that this information and the kind of support and encouragement and guidance that we are prepared to provide to you will help you master this situation such that you can make a major contribution to the recovery from the last episode and hopefully then on into a rehabilitation effort.
This video has 7 parts. How we have come to understand this disease, its prevalence in society, the inner experience, the public perspective, the role of brain function in schizophrenia, possible causes, the interaction between medication and the psychological and social environment. At the end of each section, please feel free to stop the tape to review or discuss the material.
We think it might be useful for you to understand a little bit about the history of schizophrenia. It's been viewed through history in a variety of ways, all of which have been determined by the culture and beliefs of the time. Basically, it's been surrounded by confusion up until as recently as about 10 to 15 years ago, and almost all of that confusion has led to erroneous conclusions. Especially toward the end of the Middle Ages, people with schizophrenia were viewed often as witches or perhaps possessed by the devil. Unfortunately, that often led to serious punishments being meted out to people who were, as we see today, suffering from a serious illness.
Modern medicine developed in the 19th century, and pioneering psychiatrists began to systematically describe the illness we now know as schizophrenia. It was first called dementia praecox because it occurs earlier in life, after it was discovered that it was different from Alzheimer's disease, which occurs much later. So it was seen as potentially treatable. As the illness became more clear, 4 fundamental characteristics of the disorder were described by Manfred Bleuler. These are ambivalence, the experience of mutually contradictory feelings or the inability to know what is felt; autism, a preoccupation with inner experience; loose associations or disordered thinking that is difficult to understand; and loss of affect, not having any feelings.
At the end of their work, and especially as some of Freud's work began to unfold later in his life, what emerged from that was the new medical science of psychiatry. And all of them agreed that at some level, though we didn't have the tools to understand it, the brain was crucial to this disorder.
During the early and mid-20th century, Freudian psychoanalysts and others tried to show that schizophrenia was caused by early childhood experiences, abuse, or dysfunctional family relationships. But this hypothesis did not lead to adequate treatments, so it is not widely held now.
We've come almost full circle now, however, because modern science is showing unequivocally that schizophrenia is based in a disease of the brain. That is, that it's a true illness. This is a very important development for families and people with this disorder because it means that it's not a matter of mental weakness or the fault of the family, but rather it is in the same category as other medical illnesses and other neurological illnesses. The effect, we hope, is that over time that will end the kind of rejection and the kind of stigmatizing that's often accompanied having this illness or having somebody have this illness in one's family. Today, many researchers think that schizophrenia has at least 2 or 3 different types and maybe several diseases with different courses and different kinds of treatment. We think it's pretty important that families understand that schizophrenia is not what is portrayed in the movies or on TV. For instance, it's not split personality, which is actually a fairly rare disorder. Also, people with schizophrenia have no higher rates of violence or crime than the general population, so it is not especially a dangerous disorder. What we do want to emphasize also rather strongly is that this is a treatable disease, though it's not necessarily curable. What that means is with modern medications, and especially new psychotherapies, family support methods, and rehabilitation approaches, it is not nearly as malignant a disease as it used to be. In fact, it's much more benign. For instance, with modern rehabilitation techniques, it's now possible for many people to return to work, and sometimes even to find a job when they've had none at all. So in the present period, we're really at a crossroads, especially in terms of understanding and benefiting from the effects of treatment. In fact, one of those new treatments is the one you're participating in. That is, we found that working closely with families, providing them with education, support, guidance, and getting their input on what kinds of things might be most effective to help the person with the illness, has proven to be very effective in reducing symptoms, preventing relapse, and even improving final outcomes. So, today we're in a situation where there's a lot more hope for schizophrenia than there has ever been before. And as modern research unfolds, that prognosis will probably improve steadily for the next few years. Now, we'd like to talk about how common schizophrenia is in our society and in all societies. Many families are surprised to learn how many people have this disorder and how common it is. So, for instance, about 1 out of 100 people have this disorder. That means in your neighborhood, even if you didn't have someone in your family, you'd know somebody who did have somebody with this illness in their family.
Until the advent of the new medications, people diagnosed with schizophrenia occupied 1/2 of the hospital beds in the United States. 1 out of every 10,000 people come down with schizophrenia, and 750,000 are treated every year. Several million people in the United States currently have had this disorder at one time or another in their lifetime.
Although we think of schizophrenia as a mental disorder, the lifetime risk of this illness is the same as for diabetes, which of course is an illness that one hears a lot more about and for which there's been a lot more research and treatment development. The peak age of onset is somewhat different for men and women. Men usually begin to have difficulties in their late teens or early 20s, whereas women tend to begin to have this illness in their middle 20s and even into their 30s. In this section, we're going to attempt to communicate what it's like to have schizophrenia. That is, what's the interpersonal experience? We've found that many families find this helpful, especially as they begin to understand what's going on for the person and also how that understanding could influence the way they interact with their family member. One of the things that many of the patients that we've worked with have described is that this illness really begins in a small way, with the mind playing small tricks on the person. What they've noticed is that they began having difficulty screening out irrelevant information and stimuli and paying attention to what's important. Now, this is important, and you'll hear this over and over again in our discussion. Attention is absolutely critical to conducting one's affairs. If you can't pay attention and concentrate, it's difficult to hear what somebody's saying, to get passing grades in school, to do your job, to have a satisfying social life. It makes it very hard to develop a line of thought that will be comprehensible to somebody else. And in more extreme states, it becomes completely overwhelming. As this process gets more serious and has a greater impact, the ability of the person to generalize at the correct level becomes more and more impaired. They have great difficulty understanding what's relevant, what's irrelevant, what's important, what's to be ignored.
Inputs become too numerous and unselected. There is a fragmentation of the thought process. The ability to apply past experience as a guide is interrupted. At the same time, personal internal memories get applied incorrectly to outer experiences, while external perceptions interfere with internal mental processes.
As the process continues further, extraneous thoughts and even noises become equivalent to thoughts that the person's having. The two begin to get jumbled together. That begins to increasingly interfere with the ability of the person to make the correct conclusions about what's going on and interact successfully with others in the environment. Many people describe the state of being overloaded. That is, that there are so many sensations impacting one and that you're so unable to filter them out, avoid them, ignore them, that one constantly feels bombarded by stimuli. Now, you can almost imagine what this would be like in the following example. Let's say you're watching this videotape and there's a bird singing outside the window. Somebody slams a door and a truck drives by. Normally what we would do, and our minds will do for us, is to select out what we want to pay attention to and ignore all the rest. But imagine what it would be like if all of those sounds and all of those thoughts and all those experiences were given the same weight. That is, you couldn't separate out one from the other. That's about what it's like when somebody's having a psychotic episode in schizophrenia. For many people, this occurs almost on a daily basis.
We'll replay what Dr. McFarlane just said, but this time we'll hear it as a person with schizophrenic processing might hear it.
Now, you can almost imagine what this would be like in the following example. Let's say you're watching this videotape and there's a bird singing outside the window. Somebody slams the door. Normally what we would do, our minds will do for us, is to select out what we want to pay attention to and ignore all the rest. But imagine what it would be like if all of those sounds and all of those thoughts and all of those experiences were given the same weight. That is, you couldn't separate out one from the other. It's about what it's like when somebody's having a psychotic episode in schizophrenia. For many people, this occurs almost on a daily basis. The final result of all of these mental experiences is that it would be very hard for you to pay attention to a conversation, read a book, do your work, get involved with the emotional life of somebody else. It really cuts one off from the outside world while being heavily impacted by it. The next stage of this process is that one begins to lose control not only of one's attention, but almost all willed action. one begins to be unable to do the things that one would like to do, and then finds oneself doing things over which really you have almost no control.
Imagine if you were the only person on duty at a hospital switchboard when a disaster occurred. Phone calls would be coming in simultaneously from the accident scene, ambulances, families, doctors, and the media. You would be trying to talk to all of them simultaneously, hearing none of them clearly and making no sense to any of them. For instance, asking the reporter to bring in more medicine.
Another change that many patients describe is what we call heightening of sensation. This occurs in two ways. First, the total quantity of sensations is much greater. That is, since you can't filter things out, almost every little piece of stimulation in the environment becomes registered in the mind. Secondly, as this sensory process becomes more global and diffuse, what in fact starts to happen is the quality of one's sensations really begin to change.
Sensations get altered as sound and light appear more intense than normal. Objects in the environment, such as people, are altered in terms of color and shape, appearing distorted. These hallucinations often affect people and objects familiar to the person and important in their life.
More recently, we begin to understand that one effects of all these perceptual difficulties is that the individual has a fair amount of difficulty registering feelings in other people and understanding nonverbal gestures and facial expression. So if you take that into account with all of these difficulties with attention and controlling arousal, you can see why social situations are particularly difficult for people with this disorder to manage, and why very often they would rather not participate in them. Naturally, you can imagine that as this process continues and worsens, the person would experience all kinds of errors in the way they relate to the world. So for instance, if you're walking down the street and you see a stranger, but when you actually look at them, you think they're somebody you know because they actually look like it, you'd begin to think that somebody was always there. In fact, that maybe perhaps somebody's following you. I think it's important to understand this so you have some sense of why some people with this disorder will tend to withdraw and avoid contact with people. If you think for a moment what this experience would be like, you can imagine that the more real it seemed, and it does seem very real, the more upset and anxious and nervous one would become. Going beyond that, we can find many instances in which the level of fear becomes really greater than anything most of us have experienced. It's also not too hard to understand how the person would begin to be suspicious and distrustful, because almost all of their experiences don't seem real. They don't seem normal. That can generate a lot of secondary anxiety and a lot of fear, and lead to a great deal of disruption of functioning and just downright panic. And that brings us to our next topic. As people become more and more nervous and anxious, we find that their arousal increases. Now, what is arousal? Well, it's a state of the central nervous system that leads to rapid breathing, increase in heart rate, much more increase in blood pressure, but more particularly a sense of being out of control. One finds that one's hands sweat, and really the experience is one of very high anxiety. Now, you can imagine, and this is the way it actually occurs in nature, that the more anxious you get, the more distractible you get. The harder it is to register sensations and keep control over one's mental life. So as distractibility increases, arousal increases. It becomes very, very difficult for somebody to have any sense of control over their inner life and even their behavior. Now, we're going to shift perspective and talk about what this illness looks like from the outside, from the perspective of other people. That is, what's the public experience of schizophrenia? So we've talked before about how many disruptions there are subjectively. You can imagine that one of the effects is that it's very hard to think. And that's indeed what we see from the outside. It's very difficult for people, especially during the psychotic phase of this illness, to generate thoughts that make sense, that follow a logical line of reasoning, or that track the conversation that one's participating in. They get more and more, as Boiler said, autistic, that is, coming from inside and not necessarily related to what's going on outside. So that's what we call thought disorder. It's something that families experience every day, I'm sure, and find very distressing. One of the symptoms that's most characteristic of schizophrenia is called delusions. These begin with the kind of suspiciousness that follows from the rather pervasive changes that have occurred in the person's thinking and sensations. But they begin to go farther beyond that. It begins to develop into a set of beliefs that are quite out of touch with what other people believe, and often completely physically impossible. These mental experiences are so extreme and so upsetting that the person begins to try to find explanations for them. So, for instance, they might find that they have sensations of having other people put thoughts into their mind. Some people even believe that wires have been put in their head to make these kinds of experiences happening. Conversely, some people experience their thoughts being broadcast so that others may hear them. Others believe there are forces outside themselves that are directing these sensations and thoughts to be placed in their heads. The other thing that begins to happen is that the beliefs become rather fixed, unchangeable, and really not subject to change by being talked to by some other person. Now, we've said that many of these beliefs seem to make sense in terms of what the person is experiencing internally. Unfortunately, these ideas begin to drive certain kinds of behavior that can be very disruptive to the person and even to others. As an example, suppose the individual was having a poor relationship with their next door neighbor before they became ill. But as they get ill, the suspiciousness begins to increase, and they begin to think of the person next door as causing all of their problems. Then other kinds of things might begin to happen. They might be very suspicious of this person, begin trying to avoid them, might shout at them, might accuse them of causing some of these difficulties. As you can see, that's when this illness begins to be not just manifest publicly, but really begins to be a bit of a public problem. Now, another behavior that other people can observe is called hallucinations. These are perceptions that go beyond the kinds of alterations we've talked about before and involve sensations that are quite real and quite powerful. The most common form are what's called auditory hallucinations, that is, voices that are heard that seem quite real and are often extremely loud. Sometimes a hallucination is just an illusion, very faint, but the ones that we worry about are the ones that are accusatory, that often are critical, and sometimes can suggest that people do things that might be a danger to themselves or others. These kinds of perceptions are extremely real, and families need to understand that when somebody is saying they hear a voice, that it's almost as if the voice is actually there. Now, we've described what psychiatrists call positive symptoms, that is, experiences that are added to our ordinary everyday experience. I'd like to turn now to negative symptoms, which simply means symptoms that involve losses, things that are taken away, things that are a deficit from our everyday experience. These are, even in some ways, even more upsetting to families because they're a little less dramatic, but they're quite pervasive because they rob the person of many of the important aspects of human consciousness and experience that we all hold precious.
Negative symptoms. Alogia is the reduction or loss of speech. It is due to the interference or slowing of thinking and or the desire to withdraw. Affective flattening is a loss of feelings and a narrowing of the emotional life to the point where the person may only feel anxiety or unhappiness. Avolition is a loss of motivation and interest in pursuing any goals. Anhedonia is a loss of pleasurable sensations such as smell, taste, sexual pleasure. There is nothing that feels good.
One of the implications and effects of these other negative symptoms is that the person just becomes less spontaneous, and they find that they just don't have as much fun, and unfortunately may not be as much fun as they were before they began to be ill. One of the effects of that, of course, is to begin to make people feel that they're not worth very much to others, and that, of course, drives further social withdrawal. In the end, we find that many people are susceptible to outright depression as a result of their experiences, both as in the acute phase, but more particularly as they try to recover and get back to their old selves. One of the other things that we observe as people begin to recover from their acute episodes is that this kind of perceptual and sensory sensitivity carries over to the social situation. We find that people are highly sensitive to criticism or even small comments that might be pejorative in any way. These comments might be passed over by us, but they register very strongly with the person as they are trying to wend their way back into social situations. There's a tremendous degree of self-consciousness and social awkwardness and embarrassment, which is some degree based in these kinds of cognitive and thinking difficulties, but it's also based very much in the way people are treated who have this illness. We don't exactly welcome people into our social settings after they've had a psychotic episode. If you've traced this out, what one begins to find is that the social withdrawal and the social sensitivity begin to strengthen each other. And this, of course, generates a third problem, which is that people then begin to lose their social skills over time. It's that, of course, that leads to the need for social rehabilitation and strong efforts to help people in a sensitive way get back into the social life. Now, we're going to go beyond describing what schizophrenia is and try to help those of you watching this tape to understand the ways that science has taught us to understand schizophrenia at the level of the brain and to a degree at the level of psychological experience. We're going to present a general model and some of the scientific findings that undergird that particular model in the hopes that this will help you understand the day-to-day experience that you have with your illness or with your loved one.
The model we use to help explain what causes some of the difficulties in schizophrenia is called the attention arousal theory. In normal stressful situations, like a job interview or a first date, we often find that we get keyed up. Normally, this stress or arousal helps improve mental functioning. But if the stress increases further, after a certain point, we don't do our best. Thinking starts to deteriorate. So we control this tendency towards inattention or distraction by focusing on some element of the situation. But in schizophrenia, the over-arousal from the normal stress further aggravates the attention problems. That makes the person more nervous or aroused, which interferes increasingly with the ability of attention to fend off distractions, and the vicious cycle continues.
You can understand that it would be very difficult to plan, sequence your behavior sort of thoughtfully arrange your affairs such that you can take care of yourself and be fully independent. That difficulty will only be compounded if one's faced with continuing kinds of stresses and difficult social and other kinds of environments. The implication we're getting to here is that if one has schizophrenia, one will do a bit better, in fact sometimes dramatically better, in environments that are calm, somewhat simpler, with fewer stresses and fewer changes over time than might be the case for the rest of us. It is as if much of the difficulties that we encounter in modern life are actually quite a bit more stressful for somebody with this particular disorder.
If we can reduce arousal either with medication or by controlling sources of stress in the environment, then we can improve attention, which leads to an overall improvement of mental functioning and behavior.
What we're getting to is a slightly more complex idea, and that is that schizophrenia and its outcome is partly a matter of the brain and its functioning, but is also a matter of the environment, especially the social environment. So you'll see how that gets translated into some of the family guidelines that the person working with you will be suggesting as part of this workshop, and also with the general course of recovery that we try to suggest families help to facilitate. We're going to take a look at the brain in a somewhat more technical kind of way to help you understand some of the basics about what's gone wrong in schizophrenia and where some of these more psychologically based difficulties seem to stem from.
We're looking at the brain from the side view. It is connected to the spine at its base by the brain stem, the oldest part of the brain. The brain stem, which includes the midbrain, regulates activation of the nervous system through chemicals called neurotransmitters. Dopamine, serotonin, noradrenaline, and glutamine are 4 important neurotransmitters. Together, the neurotransmitters determine levels of activity in all the other higher brain structures, such as the prefrontal cortex. They are crucial to attention and arousal, as well as determining levels of consciousness as a whole. The prefrontal cortex is the region of our higher, most complex thought processes. It integrates thinking and feeling. It is here that intentional action and goal-oriented behavior is initiated. And it is here where memory, learning, and social interaction are made possible. When researchers make scans of the prefrontal lobes, we see that prefrontal functioning is reduced by about 1/2 in the schizophrenic person. The loss of prefrontal activation corresponds very closely to thought disorder we find in schizophrenia. Difficulties in establishing organized patterns of thinking, problem solving, attention, initiative, motivation, integration of thought and feeling, and mental liveliness. The temporal area on the sides is associated with the ability to understand a language. Studies suggest that deficiencies in the way the temporal lobe processes auditory stimuli in schizophrenia may alter language comprehension. This would create misperceptions, which could contribute to the formation of verbal hallucinations. The occipital lobe is another sensory area located in the back of the brain. It processes visual information. As we can see in this scan, the occipital lobe is hyperactive in schizophrenia. This is consistent with our theory that heightened arousal in the sensory areas interferes with prefrontal mental functions, especially attention. The limbic system, deep in the brain, integrates information coming and going from the other parts. It is also involved with generating feelings. A part of the limbic system, the hippocampus regulates short-term memory and is an important control center for attention. In these cell samples taken from normal and schizophrenic hippocampal regions, We can easily see the high level of cellular disorganization in the schizophrenic example. This undoubtedly contributes to thought disorder, such as serious disabilities in focusing attention, avoiding distracting stimuli, and memory problems. The thalamus is a central control system for regulating sensory input. It has been found that in schizophrenia, its size is smaller and its activity lower. Functionally, there is a sensory overloading. That is, its lower level of activity leads to an inability to screen out stimuli and for sensory information to be experienced as excessive, inappropriately generalized, and overwhelming.
We've just looked at the brain from the point of view of its structure and its larger systems. Now we're going to take a look at the brain almost one cell at a time, as if we were looking at it under a microscope. The brain is an incredible physical structure. There are over 100 billion cells in each human brain. Someone has calculated that the number of interconnections between those cells is greater than the number of protons in the known universe. That makes it the most complicated entity that we know anything about anywhere.
Brain cells are basically all the same. Looking at their structure schematically, we see that there's a cell body, a part that extends from it to other cells called the axon, and a part which receives input from other cells called the dendrite. The cells are connected in chains over which electrical and chemical signals pass simultaneously. Let's focus on this crucial electrochemical process by examining the point of contact between the two cells, the synapse. Typically, the basic cell function involves an electrical impulse that travels through the cell body to the axon, where it causes a chemical substance, the neurotransmitter, to be released into the synaptic gap between the cells. The neurotransmitter is received by the receptors on the dendrite of the next cell, where it then produces an electrical impulse that travels through that cell body to the next axon, and so on along the chains of cells. The brain is alive with these transmission processes occurring millions of times a minute, the electrochemical equivalents of our thoughts, feelings, and sensations. Now, in situations such as schizophrenia, where we have excess arousal, there is too much chemical sensitivity to the neurotransmitter, such as dopamine, being released into the synapse. This produces overstimulation of the next cell, resulting in excessive electrical activity increasing down the chain, over-arousal that interferes with attention and thinking. But we can intervene with a chemical that is molecularly similar to the neurotransmitter. This chemical blocks some of the dopamine receptors. The blocking reduces the activity level in the receiving cell and limits over-arousal so that thinking isn't interfered with.
Most of our psychiatric medications act by occupying those receptors. That is, they kind of fool the receptor because their shape as a molecule is so similar to the shape of the natural neurotransmitter. So, if we have enough molecules of, let's say, a psychiatric antipsychotic medication blocking the receptors, it will tend to reduce the activity level in the receiving cell. Well, it turns out that the tracts in the brain that lead from the midbrain, that structure we mentioned before, up to the prefrontal cortex, and also those that lead to the limbic system, all use dopamine as their primary neurotransmitter. So that you can see that if there was hyperactivity, that means excess arousal, excess activity, and difficulties with attention and thinking, dopamine would be in excess, and any drug that blocked dopamine might prove to be helpful.
As we see in this schematic, the medication helps return to normal the activation balance within the brain. It does this by helping reduce abnormal arousal in the midbrain, the hippocampus, and the rest of the limbic system. This improves attention and helps the prefrontal cortex fulfill its other function, that of helping to regulate limbic system arousal. In the schizophrenic brain, not only are the prefrontal lobes below normal activation as we see in this scan, but the sensory areas are above normal. What we're seeing here is a picture of imbalance and loss of thought control. This state can be returned to normal balance with medication and reduction of external stimulation.
So let's review some of the causes of schizophrenia. As I said earlier, there's more thought that there may be several causes to this very serious illness. I hope this will help you understand the background. Perhaps the simplest message here is that all of these causes tend to be biological in nature. They don't involve family, errors, problems. They don't involve anything that the individual might have done to themselves. The first thing I'd like to talk about is genetics. You've probably heard that many cases of schizophrenia seem to be related to a genetic kind of transmission from generation to generation. And a few statistics help bear that out. For instance, if one has schizophrenia, there's about a 10% chance that one children will have schizophrenia, and that's about 10 times the normal rate. On the other hand, about 90% of people with schizophrenia don't have a family history for this disorder. So you can see that it's a bit complicated. We've found, for instance, that if one identical twin has schizophrenia, about 40% chance that the other identical twin has schizophrenia. Another way to think about this is that some cases of schizophrenia may not be related to genetics at all. And that would explain why the identical twin rate is not 100%. As you may know, you'd expect that to be true if the genes are truly identical in both individuals.
It is now thought that a variety of factors during pregnancy may adversely affect the early development of the prefrontal cortex. These could cause neurophysiological deficits that are not manifested until their full functioning is called upon in early adulthood. At that time, the inability to handle increased arousal from the demands of independent living may precipitate the onset of schizophrenia. We can see in this CAT scan that the ventricles are enlarged. This indicates a loss of brain tissue or failure of the brain to develop completely, which would be expressed as abnormal neurophysiological functioning. In addition, anything that could lead to even minor brain damage during or after delivery, such as complications during birth, including forceps delivery, oxygen deprivation, spinal anesthesia, also predispose to schizophrenia.
These are important causes because they make schizophrenia like a number of other neurological disorders. And that's what we're beginning to think. And in very many ways, schizophrenia is an ordinary kind of neurological disorder that has the same kind of causes as all the other ones that we already know about. While that may be news to people, it also is rather exciting because it suggests that as research continues, we may isolate more and more causes, some of which may lead to the possibility of prevention, and all of which will help us understand what kinds of treatments might be more effective. If you followed it this far, then you can begin to understand the linkage between environmental stimuli, difficulties with brain function, and some of our antipsychotic medication. We're leading up to a model that says that there's an active interplay between the environment and the symptoms of schizophrenia, and that interaction is one that we think we can affect both with medication and also in the ways by which we change the environment and try to make it more conducive to functioning and recovery. You can begin to get an understanding of how all of these things interrelate by thinking about your own life. For instance, we've all had times in our life when we faced rather extreme stresses, leaving home, going to college, breaking up with a girlfriend, perhaps losing a job. All of these things present very extreme stresses that we tend to handle with more or less difficulty. However, in schizophrenia, these are the kind of stresses that simply become overwhelming. They lead to too much arousal for the individual to control and then lead on into psychotic symptoms. Notice also that some of the secondary effects of this illness, those that are related to negative symptoms, also mean that the individual will have much less ability to deal with all of the secondary effects of a life stress. In other words, there's a kind of vicious cycle again. That is, in the pressure experienced by people as they become more independent, they find that they don't have the mental abilities that they may be required to actually function in a more independent way. Meanwhile, an acute psychiatric illness has intervened and made everything much, much more difficult for them. For some of you, you've just been through that experience and you know it full well. For others, it takes a long time for them to understand that there's a linkage between things that happen in the outside world and what goes on inside, in the brain. So we've seen that some of the ways schizophrenia affects the brain also affects one's ability to be independent. Well, that inability or those difficulties become stresses in themselves, so the cycle begins to really accelerate. Many people have said that it's exactly these kinds of life events that have often precipitated their first episode. And then they say, as we can imagine, that the inability to be on one's own becomes a part of the stress that they have to deal with, which of course then can tend to precipitate symptoms in itself. So we see that this is an illness that is a constant interplay between the brain and the outside environment and what's going on with the person caught in between. So perhaps by now it's become clear why medication is so important. The antipsychotic medications, even in taken in low doses over time, tend to reduce the sensitivity to arousal, help improve attention, and ultimately help build a basis for independent functioning. If you've been in the hospital or take these medications, these names are probably familiar to you: Thorazine, Stelazine, Prolixin, more recently drugs called clozapine or Clozaril, risperidone or Risperidol, and olanzapine, better known as Zyprexa. All of these drugs have these same positive effects and allow people to withstand some of the pressures of everyday life. In some cases, especially these newer drugs, there's some evidence that they may improve functioning and may have impacts on the negative symptoms. That is, the person over time may experience a return of some liveliness, some ability to think more clearly, some return of feeling, and most importantly, an increase in their level of drive and motivation. So, ongoing medication is extremely important, especially because it prevents relapses and going back to the hospital. Now that's important because with each successive episode of psychosis, there tends to be an increase in negative symptoms and an increase in one's difficulty in handling independent living. So we've put a great deal of emphasis in this program on preventing relapse, and one of the best ways to do that is through antipsychotic medication. As you'll see in this particular graphic, there's a very large difference in the relapse rates between those who are not on medication and those who are over time. The difference is roughly 70% of people will have a relapse in a year if they don't take medication, versus about 35% of people who take medication regularly. As you can see, those are pretty strong arguments for taking these medications on a regular basis. While they have great advantages, like all medications, these drugs do have their side effects. The most common ones include some sense of muscle stiffness and rigidity. For some people, there's a difficulty with dry mouth. Some people gain weight. Others have a feeling of being slowed down or kind of mentally insulated from the world. Those are important, but they tend to get better with time. Some people have a difficulty with dizziness and a lowering of blood pressure. That's a little bit more serious and needs to be managed and sometimes requires changing medication. There's one side effect that we worry about somewhat more, and that's called tardive dyskinesia. It can tend to be permanent. It leads to difficulties with controlling certain muscles of the trunk and the face, and is something that psychiatrists observe for very carefully, because it turns out that it can be managed relatively well if it's picked up very, very early. So make sure you and your psychiatrist have a time each year when you kind of check over how you're doing on these facial, tongue, and body movements. The other more serious side effect that we should mention is one that's associated with Clozaril. Occasionally it can affect the immune system rather seriously, and that requires the blood to be monitored for the state of the immune system. On the other side, Clozaril, Zyprexa, risperidone, these drugs seem to have a much lower risk of tardive dyskinesia. As you can see, perhaps, as each drug gets developed, it tends to have a better balance between its main effects and those of its side effects. So I hope if this section has helped you understand anything, it's that medication has a direct bearing on the abnormalities of brain chemistry that are associated with schizophrenia, and specifically help people not only get over their episodes, but prevent relapse. Finally, ongoing medication is one of the main ways to build a foundation toward recovery. That is, because of these effects on the psychophysiology of schizophrenia, it allows people to function better and therefore to build lives that are more fully independent. Many families have asked me and others about whether diet, vitamins, sort of natural healing has any role in the treatment of schizophrenia. The answer is we don't really know, and so far there's no evidence that those kinds of approaches are effective. This is a fairly serious disease and does tend to need more serious kinds of treatment. However, we have to emphasize very strongly that street drugs, cocaine, hallucinogens like LSD, and other kinds of drugs that one can obtain through illegal means are almost universally destructive of recovery and stability in this disease. For instance, cocaine produces massive release of dopamine into the very centers of the brain that we're trying to control with our medications. This is true even to some degree for caffeine and nicotine, both of which are stimulants and tend to keep the arousal level rather high and predispose people to symptoms and relapse. Some people have asked, well, what about alcohol and marijuana? Don't they depress the brain? Don't they suppress these kinds of activation problems that we're talking about? The answer is yes, they do for very brief periods of time. However, the brain interprets both of them as poisons and therefore tends to provoke activation over longer periods of time, with the result that you find that people that drink heavily or use a lot of marijuana have very high rates of relapse and almost never recover the kinds of functions that they or the families would like them to see get back. There's a few things that would be worth saying in closing that we've not brought forward up to now. The main thing we've tried to communicate is that there's two aspects of treatment that become really important as time goes forward, and also that relate to the possibility of fuller degrees of recovery. The first is medication. It's essential to prevent relapse, and it's essential to return to any degree of normal functioning. It's even more important if the individual and his or her family have somewhat higher goals for the longer-term outcome. In other words, the more one wants to do, the more stress one needs to handle in order to get what one wants from life, the more one needs medication. The other is the general notion that we need to work together to effect a difference in the way the environment presents stresses and stimuli to the individual with the illness. That's important, first of all, to assure a smooth recovery from the last episode. It just won't happen if there's a lot of other stresses going on. Secondly, we need that kind of protection in order to prevent relapse in the future. Thirdly, it's pretty important to reduce stimuli and make for a calm environment in order to facilitate the person's social and vocational rehabilitation. Again, because stresses and stimuli tend to interfere with intellectual functioning and therefore with the ability to re-enter the normal workaday world. The last one is perhaps a little more complex, and that is the notion that as the stress level is reduced in certain environments, let's say in the home or where the person lives, it allows the person then to withstand more stress out in the community, for instance, at work. This model of balancing stresses and sort of trading them off from one environment to another has been really crucial and very useful in achieving much higher rates of employment and satisfaction with life amongst people that we've worked with recently. A family support program like the one you're in is very helpful because it allows us to work together to create these kinds of special circumstances in a special environment for 1 to 2 years after the last episode. Now, we'll be working together with you, hopefully, for that time. If you'll see in this particular graphic, the course of recovery from an acute episode, you might understand better why we want to work over such a long period of time. As you can see, negative symptoms on the right-hand side of the graphic tend to diminish very slowly over time. However, the risk for relapse is roughly proportional to the degree of negative symptoms, so it also diminishes over time. What that means is that the risk for relapse is rather high shortly after an acute episode, and really if there's a significant amount of stress then, the person might relapse, and if they don't, they're highly vulnerable to symptom exacerbations and just general difficulties. In the statistics you see here, the usual relapse rate for people who don't take medication is about 70% a year, maybe 65%. For people who take medication but don't have their family included in the treatment and rehabilitation process, that number is about 35 to 40%. However, quite consistently across many studies, the rate of relapse drops to 15% if families are working in the ways that we've described here. That is, helping to create a special environment, helping to promote a slower but steadier recovery. In fact, we found that if families are working together with other families in what we call multifamily groups, the results are even better, that there are very low relapse rates and very high rates of employment achieved by the individuals suffering from the illness. So we'll be working with you to effect a rather gradual and slow and rather carefully controlled recovery process from this last episode. While this may be a little frustrating and people might hope for a more rapid course of recovery, we found that this slow, steady, and careful approach is the one that wins the race. Many families, and certainly many people that have the disorder, have asked about prognosis. I mean, what does the future bring with this illness? The answer is, at any given time, it's very hard to know what the future will bring. There's such a great variety of possible outcomes. Some people have one episode and never have another one. Others have an episode very early in childhood and have a very bad course and remain symptomatic most of their lives. Happily, most people these days tend toward the former rather than the latter, especially those that take medication, don't use street drugs, don't drink a lot, and try to keep stimulation and stresses down to a lowest possible level. What we'd like to say also is that we think, although we cannot yet prove, is that participation in advanced treatment programs like this one may help improve the prognosis. There's a little bit of evidence that that may be true, and we're hoping that there will be more. We hope also that you'll continue to work with us that is, the staff here at your clinic or hospital, to set up the kinds of conditions that will help prompt a better recovery, a fuller recovery, and in some ways maybe a more reliable recovery. And ending, I can't stress enough how much we appreciate your participation and your effort. We hope that it was repaid with the same kind of results that many other families who have done this kind of work prior to you have actually experienced. Thanks, and good luck.